So in this section, we are going to have a discussion of drugs acting on parasympathetic nervous system or cholinergic nervous system. These drugs can be divided into two types depending on their action. These are parasympathomimetic drugs, and parasympatholytic drugs. Now, parasympathomimetic drugs, they are also called as cholinergic drugs, or they are also called as cholinergic agonists. And parasympatholytic drugs, they are called as anticholinergic drugs. Basically they are antagonists of cholinergic receptors, so they are also called as cholinergic antagonists. Now first we will study parasympathomimetic drugs in detail. Now parasympathomimetic drugs, they can be classified into two broad categories. These are directly acting drugs and indirectly acting drugs. So what are these directly acting drugs? The directly acting drugs, these are drugs which act directly on the cholinergic receptor in the same manner as acetylcholine. So if this is a drug and this is a receptor, say nicotinic or muscarinic receptor, this drug will directly act and stimulate these receptors. Indirectly acting drugs, they inhibit the enzyme acetylcholine esterase. So we know acetylcholine is metabolized into acetate and choline by the enzyme acetylcholine esterase. So these drugs, they will inhibit this enzyme and will increase the amount of endogenous acetylcholine, and this acetylcholine will act on receptors and produce the required effect. Now we are going to study drugs directly acting drugs. As we know, these drugs directly act on receptors, so they can be classified into two types. These can be choline esters or they can be alkaloids. Choline esters, these are the esters of choline and some other substance. So the prototype drug in this class is acetylcholine. These also include drugs such as methacholine, bithanicol, and carbachol. Now since these are all choline esters, so they contain choline or col in their names, so that's how we can remember them: acetylcholine, methacholine, bithanicol, and carbachol. These last three drugs, they are derived from acetylcholine itself. So methacholine is derived when acetylcholine is subjected to beta methylation, and bithanicol and carbachol are derived by other methods, and these are derived mainly to provide resistance against true choline acetylcholine esterase and pseudo acetylcholine esterases, because acetylcholine is sensitive to both these enzymes. Now alkaloids, they include drugs such as pilocarpine, muscarine, and a newly developed alkaloid, that's cevimeline. I will study individual drugs. The first class of drugs is choline esters. It includes drugs such as acetylcholine, methacholine, bithanicol, and carbachol. Now, acetylcholine is a prototype drug, so we're going to study it in quite detail. So first, let us start with actions of acetylcholine. As you know, acetylcholine, it can stimulate both nicotinic and muscarinic receptors. So the actions can be divided accordingly into two types. They are muscarinic actions and nicotinic actions, which are produced due to stimulation of muscarinic and nicotinic receptors respectively. So muscarinic actions are due to the stimulation of muscarinic receptors, that's M1, M2, M3, M4, and M5 receptors. The most important ones are the first three. As you know, M1 and M3, they are GQ subtype of G protein coupled receptors. Their stimulation results in increase in intracellular calcium, which produces effect. And M2 receptor is an inhibitory type of G protein coupled receptor. It decreases cyclic AMP and opens potassium channels, which produces inhibitory effect. And nicotinic receptors, they are basically sodium channels, so they produce stimulatory effect. Now, the muscarinic actions of acetylcholine can be studied as according to the organs on which muscarinic receptors are present. So the actions of acetylcholine can be divided into certain types, such as actions on heart, actions on blood vessels, actions on smooth muscles, actions on glands, and actions on eye. So in heart, the muscarinic receptors, the predominant subtype is M2 receptors, which are inhibitory type of G protein coupled receptors. They are predominantly present in the SA node. They are also present in the AV node, and they are present in the atrial fibers. Ventricles have a low number of these receptors. Now, as they are inhibitory subtype, the stimulation of these receptors by acetylcholine causes hyperpolarization in SA nodal fibers, and which it also decreases the rate of generation of prepotential, which results in decrease in heart rate. So if this is the normal pacemaker potential of SA node, so this is the normal pacemaker potential, the phase where so if this is the duration of 1 minute, so these cycles are repeated about 72 times in 1 minute in normal individual. So this phase is called as prepotential, and it occurs because of opening of funny channels and entry of sodium through it. So once Due to sympathetic stimulation, the rate of pre-potential is going to increase, so slope is going to increase and the number of cycles will increase. But due to parasympathetic innervation, this rate of increase till threshold is going to decrease. So the slope of this pre-potential decreases, and accordingly the number of cycles are going to decrease. Say from 72, they are going to decrease to 40 to 50 beats per minute. So heart rate is going to increase, and due to opening of potassium channels, refractory period is also going to increase. In AV node, the refractory period increases and the conduction through AV node decreases, and it can result in various degrees of AV node block. Now, in case of atrial fibers, things happen a bit different. Like the refractoriness of these fibers will decrease, not increase. It is going to decrease. So it's an important point. The refractoriness of SA nodal fibers increases, of AV nodal fibers increase, but in atrial fibers it decreases, and the force of contraction decreases as well. Now, effect on blood vessels. The predominant subtype of receptors in blood vessels are M3 receptors. These are present at two locations in blood vessels. We have already discussed it in a previous section, so we are going to just go through that again. So these are present in the endothelium and in the smooth muscle. So if this is a blood vessel, these are the walls of blood vessels, tunica media, and this is the endothelial lining. So these M3 receptors are present on the endothelial lining and in the smooth muscle of these blood vessels. If a molecule of acetylcholine is present, it will stimulate the vessels on endothelium and not the receptors on the smooth muscle. So on endothelium, it will cause stimulation of calcium-dependent nitric oxide synthase, resulting in vasodilation. Whereas in case of stimulation of receptors in smooth muscles, it causes vasoconstriction through increase in calcium. And this stimulation only occurs when the vessel wall is injured, so that acetylcholine cannot diffuse to the smooth muscle. So it's a normal phenomenon to decrease the blood loss whenever there is an injury. Now, the effect on smooth muscles, it will be discussed in a few moments. So before that, we'll go through the effect on glands. Predominant receptors on glands are M3 receptors, which the stimulation of which causes increase in calcium, which causes increase in secretions. That's increase in salivation and increase in lacrimation. So it causes increase in almost all the secretions. However, it is quite noteworthy that milk and bile, they are not affected by acetylcholine or parasympathetic innervation. Now let us discuss the effect of acetylcholine on eye. So if this is a diagram of the circular muscle of iris, it has receptors called as M3 receptors, and the stimulation of these receptors will cause contraction of these circular muscles, which will decrease the size of iris. This is called as meiosis. So we can remember this meiosis and mydriasis by a simple method, like whenever the size increases, so that's called as mydriasis. D for dilatation, it means whenever pupil dilates, it's mydriasis, and when D is not present, that means the pupil constricts, so it's called a meiosis. Now this meiosis results in opening of trabecular outflow pathways, so it's quite useful in closed angle glaucoma. Now these M3 receptors are also present on the ciliary muscles or muscles of accommodation, so the stimulation of these receptors will cause accommodation spasm. In order to understand the effect of acetylcholine on smooth muscles, we should know various locations where these smooth muscles are present. These smooth muscles are present in the gastrointestinal tract. They are also present in the bladder, the detrusor muscle. They are also present in the bronchi, that's bronchial smooth muscle, and they are present in the muscles of various sphincters and in trigone of bladder. In the gastrointestinal tract, the smooth muscles have M3 receptors, and these M3 receptors are GQ subtype of G protein coupled receptors. So stimulation of these receptors will cause increase in intracellular calcium, which increases the contraction of GIT and increases peristalsis. It can sometimes predispose to diarrhea. These GIT also contains M1 receptors, which are present in the gastric glands, and the stimulation of these receptors causes increase in the production of gastric acid. Now, in the bladder, the detrusor muscle contains M3 receptors. Now, again, M3 receptors being GQ subtype of receptors, their stimulation will cause increased calcium, which will cause contraction of bladder, which will result in voiding of urine. Now, because of this use, these drugs find utility in various conditions, which will be discussed later on. In the bronchi, bronchial smooth muscles contain M3 receptors, and the stimulation of which causes increase in calcium and contraction of these muscles, which results in bronchoconstriction. Now, in the sphincters and trigones, the stimulation of these receptors always causes relaxation. Now, it also makes sense whenever there will be stimulation of M3 receptors, voiding of urine will only be possible when there will be relaxation of trigone. So, these cause relaxation in the sphincter. Nicotinic actions of acetylcholine can be understood by knowing the location of various nicotinic receptors. As NN type of receptors, they are present in ganglia, adrenal medulla, and CNS. So in the ganglia, the stimulation of NN receptors will cause stimulation of both types of ganglia, that is parasympathetic as well as sympathetic ganglia. Another important point is that the stimulation of these ganglia, it does not occur at normal concentrations. It occurs only at very high doses of acetylcholine. So once this stimulation of nicotinic receptors occurs, there will be both sympathetic as well as parasympathetic outflow, and so because these are mostly opposite to each other, so net effect will not be produced. The parasympathetic neurons will cause release of acetylcholine, which will act on muscarinic receptors, and the postganglionic sympathetic neurons will cause release of noradrenaline, which will act on alpha and beta receptors. However, if we give drugs such as atropine, which will block these muscarinic receptors, then the predominant effect will be due to alpha and beta stimulation, which will be the sympathetic effect, such as increase in blood pressure and increase in heart rate. So this will be due to ganglionic stimulation. Now, in the adrenal medulla, the stimulation of these NN type of receptors will cause release of catecholamines into the circulation. These catecholamines include norepinephrine, epinephrine, and sometimes dopamine. And their stimulation, they will stimulate the same receptors and will produce same effects such as increase in blood pressure and increase in heart rate. Now, the action of acetylcholine in the central nervous system. First of all, if you give acetylcholine by intravenous route, it's not going to produce any central effect because it cannot penetrate the blood-brain barrier because it's lipid insoluble. However, if it is directly injected into the brain or given by intrathecal route, then in that case, it's going to produce arousal followed by immediate depression. So this is the effect of acetylcholine on central nervous system. The effect of acetylcholine on the NM receptors which are present at neuromuscular junction. So acetylcholine is lipid insoluble, so as such it cannot reach into the muscle end plate. The best method by which it can reach into the muscle end plate is by giving it through ionophoretic route. So if these are various layers of skin, by some means we develop charge gradient on the sides of skin, and if this is muscle end plate, this acetylcholine will be able to diffuse and reach the muscle end plate. This is known as ionophoretic route, and it results in contraction of muscle. Now, if acetylcholine is given by intra-arterial route, then in that case, first of all, it will be rapidly metabolized by pseudocholinesterase present in plasma. So very high dose of acetylcholine has to be required in order to produce this effect. So it will produce some twitching and fasciculations. And if it's given by intravenous route, due to sluggish circulation and rapid metabolism by pseudocholinesterase, it will not produce any effect through IV route. Now, interactions of acetylcholine esterase. Acetylcholine. So if we give acetylcholine along with acetylcholine esterase is going to inhibit the metabolism of acetylcholine as well as methacholine, so the action of these drugs is going to increase. So methacholine is metabolized slowly, so it will not potentiate the effect of methacholine to the extent as acetylcholine. Now, adrenaline, it will act on alpha and beta receptor and produce its action, and in most of cases the action produced is opposite to the action which is produced by parasympathetic nervous system. So we should not give these drugs together because it would be of no use, as the actions produced will be opposite. For example, parasympathetic will lead to decrease in heart rate and adrenaline will cause increase in heart rate. So these are physiological antagonists of each other and they should not be given together. Atropine is a competitive antagonist of acetylcholine, which will act on the same receptors and will block it. Now, uses of acetylcholine. Acetylcholine, it cannot be given by IV route because it will be rapidly metabolized by pseudocholinesterase, so it does not have any systemic use because of rapid metabolism, and it's lipid insoluble, so it cannot cross the lipid barrier, therefore it has no topical use. However, the only use acetylcholine has is in the intraocular surgery. It can be directly put on the pupil and it causes contraction of the pupil. It is used as a miotic agent.